Hello all. How are you?
We're good.
Right.
Thank you.
Right. Thank you all for joining us. We're gonna just wait for a couple minutes just for everyone to attend. Any people that registered, they might be running a bit late, and we're gonna start in a couple minutes. Just a few things. If you wanna ask any questions, feel free to use the chat. The presentation is around, I would say, 35 minutes, and then we can leave another 10 minutes at the end for everyone to share the questions, and then we can go by whoever asks first. My name is Sotirios, by the way. I'm the marketing lead at PredicAire. Very nice to see you all and meet you all, and gonna have a great webinar. And yeah.
Shall we make a start? So there's a few people already on.
Yes. Okay, perfect. Let me share my screen. Excellent. Again, welcome everyone, and thank you for joining us today's webinar on safe medicines management from practice to proactive compliance. We're joined by an expert panel, as you can see, who bring diverse experience from across social care and healthcare. First, we're going to have Hiralco Davias from Tribe One Medicare, a highly experienced pharmacist dedicated to improving medicine safety and compliance in care settings. Next, Sultana Isaac Pasa from Manon Group Consulting, a regulatory and quality specialist with over 13 years in adult social care, including 8 years as a CQC inspector. Then George Richardson, a director at EMARX, who brings over 35 years of expertise in system solution and care sector, or for the care sector, sorry. And finally, we have Ketan Shah, co-founder of PredicAire, who combines business leadership and personal care experience to drive innovation in AI-powered care management. Now, before we begin, I would like to show you some of the findings that we had on the previous survey, the pre-webinar survey. The majority reported, as you can see, that their medicine administration process remains fully paper-based, with no respondents yet using AI or a fully digital solution. Also, 2/3 also indicated that they're not using EMR for medication purposes and processes. When asked about confidence in EMR or MAR data, around a third rated low, while only a quarter felt highly confident. Finally, more than half described their medicine's compliance culture as reactive, compared to just 17% identifying it as proactive. These findings, as you can see, highlight the challenges many care services face, and today's session will explore how to move toward proactive compliance through smarter system, stronger governance, and the right digital tools. Now over to you, Hiro, to start the presentation.
Thanks, Sotirios. So today I'm going to be touching on safe medicines management from practice to proactive compliance. Medicines does form a big part of our services and also part of the CQC inspection. The main area it does sit in is safe, but it does feed into all the other areas. So it does feed into effective, caring, responsive, and well-led. So medicines does cover a lot of areas. It is a very broad topic, but for the purpose of today's webinar, we're just going to focus on a few areas. So we're going to be looking at medication risk assessments, PRN medicines, medication administration records, and stock checks. And the reason we've chosen these themes are because these themes are quite common themes that are picked up during audits and inspections. So we've decided to focus on these areas today. So moving on to risk assessments, I'm just going to go over a few risk assessments linked to medicine. So self-administration, covert, crushed, and non-prescribed. There's lots more, like there you get oxygen risk assessments, and there's risk assessments for paraffin-based products, etc. But today we're just going to focus on these. So starting off with self-administration, NICE guidelines and CQC guidelines do say that when a resident moves into our facility, we should make the assumption that they will be managing their own medicines, and that is because we want to promote their independence. So we should start the conversations quite early on, ideally before admission into our service. So we should be providing them information about self-administration. And then, but in order for them to be safe to self-administer, we do need to risk assess and document in the care plan. If the risk assessment deems them suitable for self-administration, there's other processes we need to follow in our facility, like we need to have a consent form, which they are signing, and they're signing to consent to lots of areas, but the main one being that they will be keeping those medicines safe and secure, locked in a cupboard, and they'll keep the key to that cupboard safe. So although we want to support them to self-administer, I think the only difference is that they're in a home with lots of other residents that could potentially be harmed by medicines that are left out. So they just need to comply with that. So self-administration, again, does need to be documented on the MAR chart or the EMAR, because we need to distinguish what's self-administered medicines and which medicines aren't. And NICE guidelines do say that self-administration isn't an all or nothing scenario. So the resident might want to self-administer just a few of their medicines, or just their inhalers or nasal sprays or eye drops. So we can support them to self-administer medicines they want, and we can administer the rest. And the only other thing we need to sort of put into place is a check. So just making sure they're compliant with their medicines, and doing and with their consent, particularly if they're on high-risk medicines, doing a check possibly every week to check that they are complying with their medicines. If they're not, then it might prompt us to risk assess. And of course, we do need to regularly review those documentations. Similarly, for non-prescribed medicines, CQC does say that we should give our residents access to non-prescribed medicines like they would have had in their own home. So if you're in your own home, you could go to Holland & Barrett and pick up vitamins. You can go to your pharmacy and pick off medicines off the shelf or over the counter. So we should be giving our residents the same access. But within our facilities, I think the only things we need to do is get those medicines reviewed by the GP or pharmacist. So normally your GP should review them and just give the authorization that they're safe to take and they don't interact with any of the residents' regular medicines. We should document the EMAR, especially particularly if we're giving them, because we need to document everything we're giving. So the medicines need to be documented either on your paper MAR chart or EMAR, and they should be clearly sort of distinguished as non-prescribed medicines. And then we need to think about storage. So if they're self-administering them, we need to go down the self-administration route. Otherwise, we will store them for them. The next set of risk assessments I'm going to talk about is crushing or covert. So firstly, I'd just like to say these are completely two different processes, and often they get mixed up. So when I'm auditing, the forms for each of these do get mixed up and they get combined. So crushing medication or altering is normally used when a resident, when we need to alter the medication, because the resident, for example, has swallowing difficulties, or they are given medicines via PEG or RIG tubes, whereas covert is a completely different process. It's when the resident doesn't have capacity, and they're refusing their medicines. So we have to hide the medicines and give them in a hidden format, which might include crushing them, but that's still a different process that goes into the covert process. So for both processes, when you crush or give medicines covertly, when the decision's made, it is normally an MDT decision. You do need to run that information past a pharmacist. You need to send the information to a pharmacist and allow them to make a plan for the resident. Please do not take the decision to crush medicines in your facilities yourself, because there are a lot of medicines that are very dangerous when crushed or altered. So let the pharmacist or clinician make that decision. They have all the resources which tell them which they can use to formulate these plans. And if you can't crush those medicines, they'll tell you which alternatives to use. These plans then get sent to the GP. GP decides how to give the medicine, and the next part's really important when it comes to your compliance is the triangulation. So your prescription, your EMAR chart or your MAR chart, and your dispensing label must have those instructions, and all of them must. It can't be missing on one of them. So that's for crushed. Covert process is similar. I think the additional thing you need to have in place is the MCA best interest decision and your DOLS assessment, because the resident doesn't have capacity. And I think the additional thing with covert as well, let your pharmacist know what your residents' preferences are with food or drink, so that they can formulate those plans accordingly. Like, for example, bisoprolol to be crushed and given with soft food. There are medicines that interact with foods as well, so it's important that we give them that information. Next slide, please. So just moving on to PRNs, a really big area of focus at the moment, and actually CQC have just updated their guidelines on PRNs, I think just back in September. So if you haven't read them or you haven't seen them, I think it's a really good resource to refer to. So I'm just going to focus a little bit on the protocol, because that is a big area which is getting looked at, which does form your PRN management. So firstly, you need to look at cognition. Does your resident have cognition? If they do, they might be able to communicate when they want the PRN medicines. If they don't, you need to know the protocol does have to be person-centered, so you need to know your residents really well. What signs and symptoms do you need to look out for? So, for example, if it's a protocol for paracetamol and the resident doesn't have capacity, what signs and symptoms are you looking out for pain? So, for example, if they scream or shout, that might be a sign and symptom of pain. If they go really quiet, it might mean they're in pain. So you need to know your residents well and formulate the protocols accordingly. You also need to look at alternative support. So what alternative support can you offer before you move on to the decision of giving a PRN medicine? So, for example, with laxatives, can you increase fluid intake? Can you give prune juice? Can you increase fiber? For benzodiazepines, can you alter the environment they're in? Can you give them a hot drink that might calm them down? So really need to make this person-centered and think about your resident. Your resident should be at the center of this. Also look at escalation. At what point do you escalate to the GP? So at what point, or emergency services? So if they haven't opened their bowels for like more than 70 hours after PRNs, maybe that will be the point you escalate. And also think about if the residents on more than one medicine for the same condition. So, for example, if they're on Senna and lactulose, your protocol should indicate which one you're going to give first. So lots to think about with PRNs, and a follow-up again is really important as well to make sure that the PRN was effective. Just moving on to the next area we mentioned will be with stock checks. So I think the main thing I just mentioned about stock checks is please, we do need to do regular stock checks, and there's very little there's very little like room for errors. So what I'd recommend is if there are any discrepancies in stock checks that you pick up, then please follow your internal processes, do investigate, do do your lessons learned, your reflections, and do learn from them, because often it is just maybe a documentation error that's caused a stock discrepancy. And if we follow our processes, it will reduce the stock errors and for identifying what's causing them. But sometimes stock errors do cause harm. I mean, it do indicate, harm. It could be a missed dose, it could be an extra dose, it could be a double dose. Next slide, please. And just finally, just going to sort of touch on sort of EMAR records or RMAR records, and more specifically, time-specific medication. So some medicines are really important to give at the right time because they are safe at that time. So the classic is Parkinson's medicines. So they do have to be given in a very small window. And if they're given outside, it might worsen their symptoms. Paracetamol is another one. We need to maintain that 4-hourly gap. And just things to think about to make sure your medicines are given on time is plan your medication round. So, put alarms in place, for example, for Parkinson's. Do your regular paracetamols first in your round, because sometimes if you leave it, in your normal round, you might end up giving it at 10:30, 11, which will have an impact for the rest of the day, and they end up missing their last dose because it's too late. So do plan your rounds. And the last point I'm just going to touch on is EMAR versus MAR, which we'll get picked up on later, but your MAR charts your EMAR charts do timestamp when medications were given. So they are very useful in seeing when the last dose was given, exact time it was given, when your Parkinson's was given, the exact time. So there are lots of benefits with the EMAR systems. And that brings me to the end of my part, and I'll pass on to Sultana. Thank you.
Thank you, Hyrule. I'm going to speak a little bit around, how we can make sure that we're compliant when it comes to medication, and how we can make sure our care plans and our processes ensure compliance as well. So when it comes to care planning, we really do need to support safe medication. We have to ensure that our care plans are watertight. When CQC come in and review your care plans, you need to have information such as current medication, what types of medication people are on, what are the side effects. And when we talk about side effects, it's the side effects relevant to that person. What do we know about the people that we are supporting, and is that information within their care plan as well? When we talk about allergies as well, have we recorded what does a reaction look like for that person as well? So many times I will be doing compliance checks and it will say no allergies on a care plan. But when I look at the medication, for example, or the EMAR, it says that they are allergic to some form of medication. We need to fully understand, and we have to have that showing not just on EMAR, but also within the care plans as well, because it's crucial for us to know. And when we're having those discussions with our team, MDTs coming in, we need to have that information to hand. We also need to understand when medication is being prescribed, what effect does that have on things like nutrition? So when people are prescribed certain medication where they shouldn't have grapefruit juice and things like that, is that present within the care plan? It's not enough just to have it in an EMAR, it has to be within the care plans themselves as well. How we're administering, so Hyrule's already spoken about covert cross self-administration. Have we got care plans in place? Are there care plans stating exactly how they should be supported and what needs to be done? What are the preferred methods for our residents as well, and the people that we support? Do they like water? Do they like juice? Do they like their medication provided all at once, or do they like to take one by one? Do they, take their time, or do they just pop all the medication in one go. We should state that within the care plans and make them very person-centered. And obviously capacity. Do people have the capacity to consent to their medication? Even if they're non-verbal, can they provide us with consent when it's through gestures and things like that? And how do we have that understanding? We have to always also make sure that our care plans are going into the details around behaviours and time-specific pain assessments. So like Hyrule said earlier, to know what the triggers are for people, to understand when somebody is on PRN medication. So how would I know through a behaviour, maybe through the way in which they respond to certain things? How do I know if somebody needs support from us as well? Next slide, please. So what good looks like in terms of governance means that you need to make sure that when things are happening in your service, that you are fully aware. Do you know when medication incidents are happening? Are you recording? Are you learning from those incidents in your services? So many times there'll be discrepancies. So dashboards will show discrepancies, but nothing's been done about them. And when you have paper MAR charts, it's even harder. So when you have electronic EMAR, obviously you have a dashboard, it tells you what's happening. You can see what's happening in your service. When you have paper, you don't have that option available, and you have to make sure. I recently went to a service where I just asked for to check some MAR charts, some paper MAR charts. And when I counted the medication versus what was on the MAR charts, there were 20 tablets difference. Now, when I'm asking the questions, how are you monitoring this? There was no proper monitoring. Nobody was picking up that there was a discrepancy because there's no electronic when we're relying on people. So we have to make sure there's clear audit framework in place as well. When I ask questions around who is auditing, who is counting, there was no information available to me. Who's doing stock checks? They shouldn't be tick box exercises. If there are discrepancies, they have to be explained. You know, there should never be a discrepancy. If you are recording things properly, if your team are using the right coding, there should not be discrepancies within any form of MAR charts. If they're following the processes when it comes to self-administration, missed medication, or when people are refusing, so many part-time staff are using the wrong code when something has been refused and wasted, for example, versus refused and returned back into stock. That can result in a discrepancy. So there's so many things that we see, and that all links back to staff competencies. How competent are your team? Have you done competencies with your staff? Even if you have nurses within your services, you should still be competency assessing them. The reason being that you know they've worked in other services, you don't know what the practices were in other services. They're using different systems, different processes within your service. You should make sure they're competent with the way you expect them to work, not how they've worked in the past. So make sure you're always doing competency assessments with your team as well, so you're getting the basics right and you're making sure that medication is being adhered to as well. And obviously your CDs, so many times I see services and CDs are not being monitored correctly. Another thing to do is look at where other people go wrong. CQC are great at letting you know what's happening everywhere else. Make it a habit as a service to go into the CQC websites and have a look where things are going wrong in other services and learn from that. These are two examples that I pulled off of the CQC website from recent inspections, and it was around the medication standards of the services. Those of you who know, a score 2 is a requires improvement and a score 1 is an inadequate. And this gives basic information. And so many times you'll see, so where I've highlighted, you know, care plans contained inaccurate and outdated information about medicines, including medicines no longer prescribed, or support needs which had changed. So it was outdated information. It was created an unsafe environment. So many times I say to people, if you are going to list medication on a care plan, you have to be 100% sure that whoever's booking your medication in is reviewing that care plan at the same time. Because if you have one discrepancy between what's written within the care plan versus what's on your MARS, you are going to have a problem with CQC. And you see here that the service got an inadequate. I'm not saying it just for that, but there were other things that were involved. The use of emollient creams, again, were not risk assessed. There were no risk assessments in place when it came to fire safety. So we always look at these kind of things and learn from them as well, because CQC is giving you some really good bit of information that you can make sure and look at and say, oh, I think that might be happening in my service, or oh, actually, I picked that up in my most recent audit. We need to do something about this because this is what happened to the service down the road or a few miles away. Okay. Next slide, please. So some top governance red flags that you should be aware of and how you should fix them as well. Over auditing. So many times I go to services and I'm told that they're auditing 100% of paper MAR charts. Now, I'll tell you right now, if that's something that you're doing, you need to stop doing that, because when you're auditing 100% of your MAR charts, I guarantee to you, if I come in and I pick up a bundle of your MAR charts, I will find discrepancies straight away. Because it's not about the quantity, it's about the quality of the audits that you're doing, and you need to make sure that your team are picking things up. And when we're auditing, it's about improvement. You cannot be auditing month upon month upon month and finding the same issues. You're not learning. You're not learning as an organization. So it's not about how many audits you do, it's how thorough the audits that you do are as well. The lack of understanding around PRN medication. Harold's already touched on the fact that there's already been an update by CQC in September. Keep on top of those updates that are coming out and make sure that your team fully understands what is PRN medication, what do we have to put in place. So anytime a GP comes in and prescribes a PRN, what are the processes that triggers in order for you to be compliant? It's not enough to just put it on the MAR chart and say, right, PRN medication as and when. There are so many other processes that you have to ensure that you are covering. Your crushed and covert, exactly the same. There are so many other processes, not just the MAR chart. Your care planning, your risk assessments, everything has to be put into place. And the listing of your medication I've spoken about already. And make everything person-centered. So many times I look at medication care, but all the other care plans will be so person-centered. When it comes to the medication care plan, it suddenly becomes this clinical document that people start writing about. Make sure that your medication care plans are person-centered as well, because you need to understand how that person likes to have their medication, because medication can be a big part of somebody's day, and you need to make sure that is as comfortable for them as possible. Okay. Next slide, please. And that's me done. Thank you.
I think it's my turn now.
Yes.
Well, first of all, hello, everyone. Thanks for attending. And also thank you to Sultana and Hiral for their presentations. What I want to do is really circle back on some of the points they're making and explore how an EMAR solution can help support you in terms of greater compliance and greater safety, and some of the things that hopefully any EMAR system can provide you with, to give you some pointers in these directions. First of all, I'd just like to say, if you are looking to go electric, all you're really doing is taking your paper system and putting it on a computer. There's a lot more to it than that. It has to be simple to use, because if your staff can't really assimilate the processes and get to use the system very quickly, it will never work for you, especially if you use agency staff. But the big things we really want to focus on are, is it safe? Will it ensure that you are giving the right people the right medication at the right time? And are you able to prove your compliance? So we're going to look at some of the areas raised by Sultana and Hiral and show you examples of how an EMAR system should be able to support you in those cases. So if we move to the next one, please. Now here we have an example. This was discussed, the difference between covert and crushing. It's very clear here, this is crushing, it's not covert. So the person administering can see what they need to be doing. They've got the directions in front of them, and it should be very easy for them to comply with those. So this is a nice straight in your face way of saying this is what you need to do, and it ensures that you're doing all the right things and everything is date and time stamped, as somebody was talking about earlier. If we move on from there, Time-specific medication, paracetamol is the well-known one. We're using slightly different medication here for this one. But if you fill in the calendar, and it's the way some systems work, you fill in the calendar so that you know when the medication needs to be administered. And it's a great reminder. And somebody said, you know, maybe if you do have time-specific medication, get it administered earlier rather than later. There might be the facility to have priority medications, for example. So make sure it's done early, but also if the situation arises where you are about to potentially overdose someone, the system should be able to pop up and say, hold on a second, you need to take a look at this, just make sure that you are doing the right thing. Moving on from there, this was also mentioned, within our system, we provide template service user protocols. It has become a very hot subject with CQC. They, if they're coming into your home, they will want to see all of these. They're very keen on outcomes as well. So what you want to be able to do is do highly person-centered service user protocols, but you want to be able to do them relatively quickly without it being too much of a pain, to be blunt with you. The next area I want to move on to really now is stock. And then again, circling back on what I believe Sultana was saying, it's not about auditing everything, but if you frequently audit and audit certain areas, units within your home, even specific residents, this is far better quality because you're taking snapshot views of everything all the time. Now, you should, in any email system, have lots of reports available. One particular one that I would home in on here is antipsychotic medication. It's again with CQC become a particularly hot subject, and they want to know how many antipsychotic medications you have in your home at any one time. If that information is available and you can very easily produce it, then it's a great way of keeping everybody happy and proving that you are maintaining a high level of compliance. In terms of low stock warnings, I'd like to move on to the next one now. This is an example of a report. The way we calculate low stock is to say, do you have enough stock to get to the end of the current cycle? It's purely and simply as that. Sometimes you've already got your next cycle stock in, so you have got enough stock. Sometimes you haven't, and this is a very in-your-face way of being able to say, right, I can see that I need to speak to the pharmacy and see if I can get some additional stock. And these reports are available all the time and certainly on a daily basis. If we move on from there, stock audits, there's nothing quite like a physical stock audit. So you can go into a part of your stock, count what's there, and then say to the system, this is what I know physically I've got. If the system says, well, I don't agree with you, you know that the physical number is what exists. So you've then got the opportunity to investigate why is there a discrepancy, see what's happened, look at the history, do something about it, and record what you think happened or what has definitely happened. If we move on from there, finally, that's me done. That's a fairly brief presentation on a big subject. I hope you found it interesting, and I'll hand over to Ketan now.
Thank you, John, and thank you to all the other panelists. Clearly, medicines, processes, governance, and how you administer that electronically is important, but at the center of all of this is having a primary interface care management solution that kind of captures data in an effective way. And this is where, when we do collaborate, with our partners, people using their systems, you will see, PredicAire's data collating in one place. If we go on to the next screen, you'll see that PredicAire itself organically captures data through our own unique person-centered care planning solution, making sure that there's no conflicts, which is something that Sultana mentioned. Single source of truth is important, and through our organic tooling, like nutrition, like care planning, quality assurance as well, enables you to sort of do that 360 assessment over your care service, but also over your residents. Toolings like EMRX, which, single point solutions like EMRX, which, capture the administration of medicine, the data from that, flows straight centrally into PredicAire. So you're going to get a all-rounded view. If we can move on to the next screen, please. You'll see, it starts with person-centered care planning, very unique, very bespoke, which will be done straight through PredicAire. From that, you're able to then sort of bring the data in from EMR. So the next screen will show you that. Clearly, some of the data that comes through our interface, we do an API integration with EMRX. Clearly, the medicine that's been administered, it will hit the timeline. As soon as it hits the timeline of that individual, you're building up a picture. You're building up a picture not only on the medicines, but also all the other care records that you capture. The reporting aspect is important as well. The next screen will show you, the kind of reporting that we can do around EMR, very bespoke, single source of truth that will be sort of coming through this. Very important for us to have sort of one single entry point, if it's required through other parts of the system. That one data entry will feed through to the other parts. So therefore, you do not have, as Sultana mentioned, conflicts in terms of data, but at the same time, making sure that when you do your audit, it's clean and it's relevant, and the red flags go away. The next slide will show you an example of some of the audits that are available within PredicAire, and it speeds up sort of your compliance, I guess, in terms of the effort required to complete, because it's a very structured process that we have that users can follow. Next slide. So you've heard a lot today from various panelists. If you are ready to supercharge your care service, go through the digital platform toolings that are available, do contact us. On screen you'll see everyone's contact details. Clearly there's a lot more we can say and speak about this topic, but time is of an essence and we're restricted to that. I guess Soterius, maybe we can take some questions. Is that a good place to be at now? Soterius?
Yes, we are. Yeah. We can move ahead with the questions. If anyone has a question, you can drop it in the chat and we can take it from there. We have around 7 minutes, but we can, if we need be, we might need to go above that.
That's okay. I can see a question coming through in terms of the slides. We can make the slides available for sure. And clearly, there's a lot more detail. Each of the panelists with their expertise that can go into a lot more detail. Please do contact each one of us individually, but at the same time, Sartorius, if you can circulate the slides to the attendees, that would be good.
Yeah, absolutely. Check if there's any questions. It's for Hiro, and when you were talking about pharmacy supporting on convert or crash meds, does instructions have to be on label and prescription?
Yes, I've just seen the question. So yes, it does have to be on the label and on the prescription. So I'll give you an example. I think I was there was a service where CQC were inspecting a home. One of the medicines on the EMR didn't say via PEG, and that did raise a non-compliance. So I think what you need to think about is if you've got a resident, for example, on covert or crushed or on a peg, think about the safety of that resident. So the instructions do need to be on the EMAR as well, not just on your risk assessment. Because just say that you had a team member that called in sick, you had an emergency bank or agency staff that came in, they went straight into the EMAR, didn't have a chance to look at the care plan or risk assessment. If that EMAR doesn't say to give via PEG for that, or crushed or covertly, they might give it normally, and that can cause quite a big risk, especially if the resident's got swallowing difficulties, and that it can end up as a choking incident. So yeah, that triangulation is really important. It's important that the instructions are on the EMAR, on the prescription, and on the risk assessment, and all those should be matching. I hope that answers your question.
Excellent. And we have another question for Sultana. How can services create a culture that values medicines compliance rather than seeing it as tick box exercise?
That's a good question. It's about creating a culture that is a learning culture. So it's not just looking at the end of the month, we need to do a medication audit, we need to do counts. It's about when we find things that are not quite right, is to create a learning culture. So teach our team, learn from when things aren't right, and put them right, but also make sure it doesn't happen again. So encourage people to share when they find discrepancies. Okay, let's start pathway tracking. Let's figure out what went wrong and let's learn from that situation. So that's where you can become less of a tick box organization and become more of a learning organization.
Excellent. And then we have one for John. How can digital tools empower sorry, I missed that. Now all the questions are coming through. Care teams and reduce human error in day-to-day administration.
Sorry, I missed some of that.
Sorry, yes. How can digital tools empower care teams and reduce human error in day-to-day administration?
Well, we talked a bit about safety. I mean, the way I have to be parochial and talk about our particular product here, but we heavily use barcoding. So every medication has got a unique barcode, which is associated with the resident. So if you've got the resident open, on your system and you are going to try and give them a medication and you scan it, then if you've picked up a medication that might actually be the right medication, it's just not their medication, the system will tell you that you've got the wrong medication. So I think the first thing here is to make sure that you're not making a mistake and picking up the wrong med. From there, it really is a case of ensuring that you've got the all the right instructions. I think Hiral was talking about this, and that's where your integration and relationship with the pharmacy is incredibly important, because you as the care home need to work with the pharmacy and vice versa at an individual resident basis to say, this particular resident, they've been prescribed, take one tablet a day. There's no specific time given, but we know that they'll never take it in the morning. They always want to take it maybe at the lunchtime thing. So you can make sure that you really stylize it and personalize it in that respect. I hope that goes some way towards answering your question.
Thank you. And another one, will the filtering on observation come back? And one person says, I just think that the observation tab could become cluttered with the meds OBS, and info will be easily lost if you can't filter the category you need to look at. That is a general question. Well,
it's probably a question for PredicAire and maybe EMRX.
Yeah.
Certainly on PredicAire, when the meds are sort of appearing on individual daily timelines, it is categorized appropriately, and it's organized in a way where it's not lost. You can use search functions to sort of filter accordingly, but at the same time, the reporting tool, the reporting function, grabs a very unique and bespoke sort of customized extraction in terms of the periods you're looking for. So it would not look cluttered, because we'd organize it. It's organized in a way where it's actually very from a user interface perspective, very friendly to interact. And I'm sure it's probably the same for EMRX, but I'll let John sort of answer that.
Yes, I mean, one area in particular is PRN outcomes, where people get reminders to check that if a PNR has been administered, has it worked or has it not worked? So that is another way of reinforcing the fact that you are making sure that whatever you're doing is actually having a positive effect or not, as the case may be. I think observations generally are more contained in the care management side, Ketan, than they are with ourselves, unless it's down at a very specific level.
Correct.
Excellent. And this one also for Sultana. I complete medication audits weekly for 3 weeks, then a monthly audit on the 4th week. Is this too much? Is it not enough?
That's a difficult one to answer, not knowing the service. It all depends on the challenges within your service. Now, I guess the thing is, what CQC would look at is, what does your policy and process state? Are you following that? And what is the purpose of you doing every once a week? So self-administration audits, yes, they would be done weekly, because obviously you need to know if somebody is compliant with their medication weekly, if they're self-administering, because if you wait till the end of the month, then they've gone a whole month and they've missed quite vital medication. However, what is the reasoning behind doing weekly medication audits? And then that 4th week, is it just another audit, a 4th week audit, or is it a bigger audit that looks at more things and maybe looks at trends? And is that more of a governance report? It's about understanding why you're doing something. And sometimes you might get things off the shelf, or you might think, put in a process because you saw someone else do it, but it's always worth asking yourself the question, what is the outcome of this audit process that I'm doing, and what is the improvement that I'm bringing into the service? So I can't give a definitive yes or no on that one. It depends on your service and what the outcome is. If you've got a lot of concerns, you've got high risk, and there's a lot of risk within your service, maybe weekly is absolutely right for you. But if you haven't, then the question is, why are you putting yourself under all of that strain if there are no concerns with your service?
Well, I think just to add to that, I think Sultana did mention it in her presentation, but think about quality. It's about quality auditing rather than quantity. So if you're doing quality weekly audits, but they're not picking, it's more of a tick box, you could maybe extend them. In some services I support, some of the audits I say do it 2 monthly, because you don't need to do this one monthly. You can split your audits up for medications. There's so many areas to look at. So some might need to be weekly if it's stock counts, etc. But areas which don't change much, you can extend a bit longer. But I think the key is quality auditing, and picking up areas and working on them and having action plans.
Perfect. And another one that's directed at you, Ketan. Is it possible to record medication information in the PredicAire system for clients who live in their own homes and self-administer their medicine, showing only whether they have taken or not taken the medication, without including detailed prescription information?
I mean, our system has a sort of a general area where you can actually capture information like that, but I would not recommend sort of medicinal information being captured in that way at all. I think it's important to have a structured process, toolings like EMRX, single point solution, which will give you that data that's been administered. And then that data will then come centrally into PredicAire to then be able to do things like appropriate governance, compliance, appropriate processings that you're following. So even if it's simple medicine taken, not medicine not taken, the impact it could potentially have on other parts, nutrition impact, for example, or even allergies. You want to make sure that you capture that appropriately. So to answer your question, is there a place to do it in an unstructured place? Yes, but I would not recommend it, purely because you have toolings like EMRX. They're able to capture that more structured way.
Excellent. Thank you. And one last one, let us know if you have any more questions after that. Do you have an example of emollients risk assessment, and can this be shared between all services or any other risk assessments related to medication?
There would be many examples. I'm sure Hero Sultana will also have examples to share and circulate. So maybe what we do, Soterios, is if we collate some examples, and then as you circulate the slides, circulate some examples overnight as well.
Yeah. To all those that attended, we're also gonna send you a certificate of attendance as well, along with some medicines checklist provided by Tribe One Medicare, and yeah, in the next few days. And also the recording will also be available. You're also gonna receive an automated email from the teams. So yeah. Let us know if you have any other questions. We're like 5 minutes above our allotted time, but you know, we can, if you have any other questions, that would be amazing. If not.
Yeah, thank you so much. Thank you so much, everyone, for attending, and thank you to our panelists as well. You know, it's an important topic. Do contact each one of us individually if you have any specific details that you would like to discuss.
Yeah. Thank you all.
Well, thank you, everybody.
Thank you so much, everyone. Have a good day.
Thank you.
Cheers, everybody. Goodbye.
Bye-bye.
Soterios, do we stay on, or do we exit?
We can move to another, move on. Thank you again. Bye-bye.
Okay, thank you.
Ending the event.